Hello, I'm Jenna Colson, speaking today on behalf of the Carter Center and other partners in the state and local ministries of health in Nigeria. Our topic is the integration of schisto and soil-transmitted helminth control programs into primary health care in Nigeria, reporting on our mixed method study from 4 districts. Both schistosomiasis and soil-transmitted helminths are widespread in Nigeria, but global funders wish to stop supporting these programs, transferring their implementation to the country's primary healthcare system, also known as mainstreaming. So the challenge we were addressing today is how do personnel tasked with implementing these programs respond to the withdrawal of support, and how does the coverage of SCH and STH prevention get affected by the mainstreaming process? The study was conducted using mixed methods, both qualitative and quantitative, looking at treatment coverage and community attitudes and perceptions in 4 districts of Nigeria, both before and after a mainstreaming effort. As a quick overview of the conclusions, we found that Nigerians confronted with the mainstreaming process were highly skeptical that it would succeed and expected children's health to be negatively impacted. And we found that mebendazole, which is used to treat STH, the coverage was quite similar after mainstreaming, but we did see some weaknesses in terms of access to praziquantel, which is used to treat schistosomiasis. This project had 3 key objectives. First, to transition schistosomiasis and soil-transmitted helminth treatment programs to the primary healthcare system or routine health services in select districts currently supported by the Carter Center. Second, to evaluate the effects of transitioning the program to full government ownership by comparing treatment coverage among the target population before and after the transition, and to evaluate and supplement this with qualitative data. The third was to develop recommendations based on study findings to inform the Schisto-STH transition plans for other districts and states in Nigeria. A primary question was, how will the treatment coverage of a district SCH-STH program in Nigeria change when the district transitions from partial support by an external partner to full support by the various levels of government involved? And the secondary question was, how will transitioning support from external partners to local government affect the distribution of responsibilities and the mechanics of MDA among staff from throughout the local health system? As mentioned, this was a mixed method study using quantitative and qualitative components. The quantitative study consisted of an MDA coverage survey that took place both pre and post transition to government management. It involved 30 communities in each of 4 districts at both time points, with systematically selected households and the target sample size of 1,435 per district. The qualitative study consisted of focus group discussions and key informant interviews. The focus groups, there were 9 that had an average of 9 participants per focus group of key personnel in health and education, and they did participatory mapping of the NTD program. The key informant interviews involved personnel in health and education, about 56 of them overall. Both used structured interview and discussion guides, were transcribed directly or summarized by local staff, and underwent content analysis. Some limitations to the surveys. Young children or school-age children are the target age group of the MDA, and some of the younger children may be less able to recall details about their MDA, and there might be some element of confirmation bias. But this is as likely to affect pre-transition as post-transition coverage surveys. Furthermore, the praziquantel for schisto was more targeted and had a smaller sample size of participants that it was relevant to compared to mebendazole. The limitations to the qualitative methods, there were time restraints and also interviewer skill that could both affect the follow-up that happened in the discussions and the structure, and also that mainstreaming as a concept was abstract and unfamiliar for most participants. This slide shows the geographic context of the 4 study sites, which consisted of 1 district, or LGA, in each of 4 states: Plateau, Nasarawa, Edo, and Delta. Briefly, the results from the quantitative portion, the coverage survey, included 11,901 school-age children, or children aged 5 to 14, across 5,972 households, including 6,112 school-age children pre-mainstreaming and 5,789 post-mainstreaming. Pre-mainstreaming, the coverage was generally good across school-age children, and most distributions occurred in schooled. schools, given that the coverage did tend to be lowest among unenrolled children. During mainstreaming, approaches for distributions included parent-teacher associations, immunization programs, local governments, community volunteers, and senior or previously trained staff. We found that post-mainstreaming, the coverage tended to drop a little bit, but not significantly. The results on the right show the differences for mebendazole before and after treatment. The differences in praziquantel were a little larger, and they're not shown here, but given that there's a more limited target geography for praziquantel distribution, there were smaller sample sizes, and it was more sensitive to village-level variability, being strongly affected by selected villages where no MDA occurred. And that also made the comparisons for praziquantel a bit harder to interpret and less statistically significant. From the qualitative components of the study, we found that overall respondents were quite concerned about the sustainability of MDA following mainstreaming. Some of the recommendations for effective mainstreaming included clear budget allocation by the government, robust training of all involved parties, and advocacy to stakeholders and community members. Respondents viewed the Ministry of Health and the state and local governments as minimally involved in the program planning, training, transportation, and overall drug distribution. The health director of one area, for instance, said the government has solely relied on TCC for the technical and other support, and the sudden transition will cause a lot of undesirable changes. Access remains a key challenge to the school-based MDA system, and also advocacy, planning, and trust building among stakeholders are considered to be really key for mainstreaming success. A health worker from one area said, "The Carter Center should pay an advocacy visit to the governor himself. Make him know the importance of these diseases, though they are neglected. Let him know that the Edo State Indigenes are suffering from these NTDs. Let him see the priority of continuing the program." So some promising practices that were encouraged by this study are to seek clarity into how an international non-governmental organization's support is and isn't relied upon in long-standing neglected tropical disease programs. A lot of our respondents overstated the Carter Center's role in program operations, which in turn weakened their faith in local authorities' ability to sustain the program. It's important to begin querying about transition perspectives early. Many years of transition planning and implementation are necessary to ensure that it's smooth and that the program is sustainable. Respondents wanted the Carter Center to remain involved with the NTD program in Nigeria for up to 4 more years, but that is far beyond the scope of this project. It's important to undertake widespread advocacy and sensitization to promote awareness and engagement among key stakeholders, such as the ministries, local government, community leaders, and also members of the target population. And also, we can utilize new and existing partnerships to facilitate the program's sustainability by supplementing the government's effort and resources. Some lessons learned from this project were the need to strengthen qualitative skills for improvement of the qualitative component of the study. Some of our interviews and focus group discussions could have gotten at more specifics and nuances that may or may not be evident to the external reviewers, which weaken the data quality. A mitigation is to ensure that interviewers are prepared to thoroughly probe and effectively probe to capture attitudes and experiences around relevant issues. Second, there's a need to clarify roles, responsibilities, and timelines. The participants wanted the Carter Center to support the program for up to 4 more years beyond the scope of this project. Mitigation is to clearly document what specific support is desired and work with the government to plan the full transition. Finally, we need to identify the weakest points that are at highest risk for challenges to MTA distribution. The challenges encountered included the school schedules, drug logistics management, and the training expectations, which all threaten the success of MDA. It's necessary to clarify the consequences of failures at different points, develop our backup plans, and adjust expectations. In conclusion, this study presents steps that Nigeria can take towards full ownership of their NTD control program, potentially helping to inform Nigeria's official NTD master plan. A few topics for future research include longer-term outcomes of mainstreaming, what happens when mainstreaming is done over a longer time frame, an investigation into the barriers to integration within institutions, procedures, and in the skills and motivations of staff. The SCH and STH program is popular and dear to the people of Nigeria, and they are committed to its success. Finally, thank you to the donors, the participants, and all of the study staff involved in this study.